Hi there, and welcome to the While You Wait podcast. We work to bring you stories of humanity, care, and hope from across the Arkansas healthcare landscape, all while you wait to start your day. Our series is hosted by the staff at the Arkansas Behavioral Health Integration Network, a local nonprofit dedicated to better health for all through integration. Today we have project manager Caitlin Johnson and myself, peer specialist Megan Copeland, as your host. On today's episode, we explored the topic of stigma between colleagues, specifically between peer support providers and other care staff. We are grateful for the chance to talk with Dori and Shawn as they share their perspectives on healthcare, recovery, and how peer services fit into the care team. We will get to that in just a minute, but we are a new podcast, so please remember to subscribe and share wherever you get your podcast. Also, feel free to drop us a line at abhinnetwork.org. Also, feel free to drop us a note at abhinnetwork.org for any feedback, questions, or episode suggestions. With that housekeeping done, let's get started with the episode.
We are just so excited to talk with Dori and Shawn. But before we get to that, we really want to give you some context, give you an idea of who we are as Arkansas Behavioral Health Integration Network, and why we chose the topics that we're choosing to discuss in this series, and why we even named it the While You Wait podcast. So in order to give you that context, we're going to discuss something that's really near and dear to our heart, which is behavioral health integration. And if you're not familiar with that term, behavioral health integration is a medical model that takes a behavioral health clinician and integrates them into an ambulatory setting. So like a primary care office, or maybe even a OBGYN office, just an ambulatory outpatient setting. And from there, that behavioral health clinician, which is typically called a behavioral health consultant in that setting. You'll hear me use that throughout the rest of the episode. The BHC then sees patients that are referred to them from the primary care provider. And to set the scene a little bit for you, typically the patient is roomed by a nurse or an MA, and they are having their vitals taken, and they're having screeners done, asking, have you had depression in the last 2 weeks? Or how's your sleep? Any food insecurity at home? Any pain? Anything like that? And then on a good day, the patient's waiting maybe 15 minutes for their primary care provider to come in the room. During that rooming process, the nurse asking all those questions is looking to see if that patient needs a behavioral health service. And when they do, the nurse will come and get the behavioral health consultant, and then that consultant goes into that room and provides that 15-minute intervention while that patient is waiting for their doctor. So we thought this podcast name was a clever nod to those consultants out there that are doing the intervention while that patient is waiting for their doctor. But what we also realized too when we were discussing it was that these healthcare workers also have a very busy schedule. It's an acknowledgement of the fact that you guys are working from sun up to sundown, and that you don't always have extra time to do these educational opportunities. So while our target audience is healthcare workers, those that are on the front lines, in the trenches, boots on the ground, that are seeing patients often for the first time in their journey of recovery, we wanted to make sure those precious pockets of time that you do have to yourself is used wisely. So we created this podcast for you to enjoy while you're waiting in a carpool line, or maybe while you're walking through the grocery store. So one of the conversation points that we often have about behavioral health integration, or BHI, is, does it work? Is all this effort for nothing, or does this actually work? Health systems ask, are there cost savings? Is our population really getting healthier, or is this kind of a tall order, right? The answer is a resounding yes. BHI definitely works. And there's many studies showing how on several different metrics, how much behavioral health integration with a mental health clinician or a peer works well for a healthcare system and a healthcare team. One of the biggest things that I noticed in my research of just how BHI is helpful, it not only is cost effective, it's saving, I think I read, a pediatric practice about $9,000 a month with just the implementation of a part-time clinician. which is astronomical for not just the health system, but also the patient being able to save on their medical costs. Another aspect of behavioral health integration is that it improves patient outcomes. You're seeing such a decrease in A1Cs or the use of an inhaler or the, helping somebody with weight loss, because someone with the expertise on how to set SMART goals and how to provide brief evidence-based interventions is right there in-house and accessible, easy to use and available. Another aspect of behavioral health integration that's talked about often is that it improves provider experience. So it's not a new concept that healthcare workers are burning out. We are in a pretty severe healthcare shortage, and I'll talk in just a few minutes about how our primary care providers our numbers are shrinking in Arkansas. But BHI has been shown to be one of the effective interventions to help with burnout, because these behavioral health consultants are able to come in and take some of the load off that primary care provider, especially when it comes to mental health diagnoses and treatment, and allows them to be treated in-house and allows the provider to still be an important quarterback, if you will, of their care, but it doesn't make them solely responsible for every part of the healthcare continuum. So, one of the hallmarks of behavioral health integration is extending that provider schedule. Kind of going back to the very first thing that I talked about, the physician is able to go and see 2 other patients while that behavioral health consultant is in there providing that brief intervention. And it really extends the healthcare team to be able to work at the top of their license every single day. Now, with it being an extender, it's an important note that this is so needed in Arkansas. I would say probably the most needed in Arkansas right now. I attended a conference last week that gave some phenomenal but scary numbers on primary care in Arkansas. There is roughly about 1 PCP per every 3,500 patients in Arkansas. So imagine being responsible for over 3,000 people yourself. No wonder there's burnout going on. And then they were looking at the number of providers in the state that are 60 and older. So about a quarter of our primary care providers in our state are either 60 or older, which means that they're getting close to retirement. And 27% of those are no longer going to be in the workforce, which means the 3,500 patients that they're responsible for are going to be shouldered by another provider when they're already shorthanded. One of the things that is important to behavioral health integration is the management of chronic conditions. Those are your diabetes, your COPD, your congestive heart failure, obesity, tobacco cessation, among other things. And what I recently learned was that chronic conditions are actually worse in rural areas than in metro areas. Our state is 41% rural. So when we're looking at our population as a whole, there is a large chunk of people that are suffering from an increased amount of chronic conditions and a decreased amount of healthcare workers in their area. Not only are chronic conditions increased in those areas, but they also have a significantly aging population. And that means that there's an increased age-related diagnoses like dementia on the rise. Another thing that I heard at this conference recently is that Arkansas has seen a very big spike in Medicare beneficiaries, or rather Medicare Advantage beneficiaries, which means that we are having a rapidly aging population of 65 and older. In fact, Woodruff and Stone County, both rural counties, saw an 100% increase in Medicare Advantage beneficiaries in the last couple of years. So that means that these primary care physicians are taking care of an aging population, and working with an insurance that may not be that easy to work with. One of the things that they reported is that these advantage plans can cause delays in care because of denials. They also add some burdensome workflows, more complicated coding, and then ultimately some delays in payment, which you can imagine is hard for a large health system to manage. So looking at it on a smaller scale, it is more difficult for a smaller clinic to sustain that. So if you can't tell by now, I am very passionate, as well as ABHIN is very passionate about integrative health. One of our key points, and it's obviously in our name, and it's a part of our mission, is that we want to increase access for all through integration. We find that is one of the best ways to do that. We find that empowering the people of Arkansas with education, training, cultivating relationships, and advocacy really empowers these people in these communities to make sustaining change. And I'm telling you, it just takes an idea, which is just how ABHIN was created. It was built out of a CPC Plus work group, and I know some of the healthcare workers listening know exactly what CPC Plus was and how fun that was. But those who don't know, it stands for the Comprehensive Primary Care Plus Payer Program that was from CMS a couple of years ago. And it helped shape a lot of health systems population health approach. But there were several different sub work groups that happened in different regions. And one of the work groups was behavioral health integration. And just so happened that our CEO, Kim Schuler, and our co-founder, Dr. Patty Gibson, were in the same group. And they got together and brainstormed and put their very smart brains together and came up with the idea that Arkansas really needed a behavioral health integration hub, a central place where people could come and get as much information and as much education from evidence-based intervention and from national speakers in one convenient place. We really have a diverse team of educated professionals that make up ABHIN. We have varying levels of licensure with social workers. We've got experienced grant writers and project managers, a lawyer, psychiatry consultant, peer specialists, people that are in long-term recovery, and people that live in both the metro and rural settings. And this team was cultivated with the idea in mind that we wanted to reflect as closely as possible the population that we are serving. And we have just a special interest in that rural area in Arkansas. We find that these communities are in a lot of need. And as I said, Arkansas is 41% rural, which could be great. I come from a rural area in Southwest Arkansas. I had 700 people that lived in my town when I graduated high school. And there is such a sense of camaraderie with people who live in rural, small areas. It's really about knowing your neighbor and being there when you're needed. So I think the family-like atmosphere in a lot of these small towns is such a perk, but then you look at the other side of it, and it's really hard to find care sometimes. And whether that's because of stigma or just because there's a healthcare desert and you have to drive 3 or 4 hours just to find a specialist or even a doctor that's taking your insurance. So, one of these things that can be hard to find care for is substance use disorder, which turns out is a very common thing that plagues a lot of families, even in rural areas. And I was doing some research on this, and there's such a high number in the U.S. In fact, 48.7 million people aged 11 or older had a substance use disorder diagnosis in the past year. So it's about 17% of our population in the U.S. And if we drill down even more as far as overdose deaths, there was 107,000 deaths in the United States in 2021, which actually is an increase of 15% from 2020. Now, let's get even further into the statistics there and look at Arkansas specifically. And this number comes from the Vital Statistics Department, that in 2021, there were 546 drug overdoses in Arkansas. So when we're looking at the grand scheme of things and we're considering all the numbers that I just provided, 500 people doesn't sound like a lot, but I do compel you as healthcare workers and as family members yourself, that if you had to ask yourself how many people are okay to pass from overdoses in your family, the answer would, I hope, would be zero. So in hindsight, while 500 is not a whole lot compared to 48 million people, those 500 people are still Arkansans that are dying. And no, 546 people are too many, right? That's 546 people too many. So one of the biggest threats in Arkansas right now is opioids. And you hear about all kinds of substances. Arkansas is not new to methamphetamine or heroin or cocaine or marijuana or anything like that. We're not new to substances, but what is new is this emerging and increasing threat of opioids that continue to grow stronger. So for those out there that aren't sure what an opioid classify as, is you've got illicit opioids, right? So heroin and fentanyl, depending on where you get it. But then you've also got so many prescription opioids that you probably have heard of, morphine, codeine, methadone, oxycodone, hydrocodone, normal things that are given to you after like a gallbladder surgery or a knee surgery or something, and then I said, depending on where you get the fentanyl is prescription too. Things like Dilaudid or Suboxone. So these very common medications are actually one of the biggest threats to Arkansas right now, because illicit use or substance misuse is on the rise. There's a lot of mishandling and misuse of these medications. So just to kind of point out how serious this problem is, it's not just Arkansas. 75% of the U.S. overdoses right now are due to opioids. 75%. And we can't ignore how much of that is often fentanyl. We know that fentanyl is about 100 times more dangerous and more potent than morphine. And there are often times that medications or illicit drugs are laced with fentanyl. So oftentimes people are not even consenting to using fentanyl, but they're getting contact with it regardless. Arkansas is unfortunately second in the nation for prescribing things like opioids, and we can't help but assume that that's led to the astronomical increase of 250% fentanyl overdoses between the years of 2019 and 2021. And I can confidently tell you that that's underreported because of stigma or maybe workforce shortages with the coroners, but we know for a fact that overdose deaths are typically underreported because of a variety of reasons. And again, one of those being stigma. And stigma is one of the reasons that we're here talking today. Stigma really permeates many aspects of healthcare. And it's not just substance use. This is a diabetes management, weight loss, smoking, depression and anxiety, just having conversations about that with your doctor. And again, especially substance use disorder. There's lots of ways that we're able to combat this, and we'll go over those, especially with Shawn and Dori. They're going to have some great insight. But some things that we can do right now as clinicians, as healthcare professionals, is start using evidence-based screeners routinely, making sure we're not missing these people as they come in our door and ask for help. Using these screeners as a way to start a conversation instead of waiting for the patient to do so. And as healthcare workers, taking the responsibility to give them the best care possible. Utilizing safe prescribing practices and considering alternative pain control options is also a way to combat some of the stigma that's associated with talking to your doctor about substance use disorder. And then, of course, using peers in your healthcare setting. What better way to get someone the care that they need than utilizing someone who specialized in that care? Peer support specialists are really on the rise in Arkansas. And I don't want to take too much thunder here because Shawn's going to give you a great overview of it. But for those who are new to peer support and not sure exactly what they are, these are people that have been in long-term recovery. They've been successful in their recovery process and have a passion of helping others find that recovery too, whatever that looks like. And to make sure that these opportunities are as useful as they could possibly be, we decided to make this a CEU opportunity because, again, you don't have a lot of time outside the clinic to keep up with your license requirements. So all these things went into choosing the name of While You Wait. And ultimately, it is an opportunity for someone who's interested in this type of healthcare model to find the education that they need for it. We're really hoping this podcast is a continued effort, not only to educate Arkansans, but to amplify the voices of those doing the work in the state, because we find that one of the biggest keys to healing is community, and who better to care for Arkansans than Arkansans? So by discussing health inequality and how we can make even the smallest changes in these ambulatory settings, we feel like we're helping lead change in Arkansas, no matter how big or how small, by leading conversations like the ones we'll have today about peers and stigma. The great thing about the podcast is it's a shared responsibility. You're going to hear from a lot of different people on our ABHIN team. Of course, you've got me today, Caitlin Johnson, and then you've got Megan Copeland. Our next episode will be hosted by our CEO, Kim Schuler. Our entire team has such a wide variety of expertise. So sharing the responsibility of hosting with each other is more about giving you all the opportunity to pick our brains, to hear how different disciplines think and where we can go from there. And ABHIN really flourished. We've really got a large range of skills that we're able to offer, and that a lot of projects that we've got being worked on right now. For example, we've got a couple of federal grants, one being the AROUT grant, Arkansas Rural Opioid Use Team Education, where one of the missions of this grant is to reduce overdoses in Arkansas. And we've got a couple of ways that we're doing that with opioid education, both in the community and in primary care clinics, Narcan trainings in all of our target counties with nalox box installations, and we're also giving out free Narcan at these trainings. And then we're going in and we're working with the healthcare providers in the area to help them develop workflow implementation, data collection, providing education and assistance on crisis intervention and how to screen routinely for substance use disorder, making sure no one falls through the cracks. Another thing that we're doing is medication-assisted treatment, kind of workflow development with a lot of the clinics in our target areas. MAT, or medication-assisted treatment, is a little bit of a new concept in Arkansas. So bringing it to primary care clinics to make it even more accessible, especially in these rural areas, is crucial and very honestly life-saving in a lot of instances. And then just a number of private contracts. You may have seen from some of our social media that we've got a Masters of Social Work integration program going on in partnership with Arkansas Blue Cross Blue Shield, the University of Arkansas, and the University of Arkansas at Little Rock, that we're very proud of. We've seen a lot of good done through these students last year and this year. In fact, we saw a overall 12% decrease in depression symptoms from last year from the efforts that our students made. So we are just so thankful at their efforts and dedication to healthcare. We also have another initiative where we are helping implement peers into emergency department rooms across rural Arkansas. And Megan is actually on that grant, and she'll share a little bit about that. I think we need to thank our listeners for tuning in and taking an hour out of their busy schedule to listen to this inaugural episode of the While You Wait podcast. We are so excited that you're joining us, and we know that you're going to find these conversations just as important as we do. Some of the content that we discussed in today's episode could be triggering for some, so we encourage you to use discretion and to reach out to your support network when needed. If you're looking for CEUs, stick around until the end of the episode and we will give you instructions on how to get those. You might hear a small difference in sound quality in this episode. In true social work and nonprofit fashion, we are traveling and out in our community. So we appreciate your grace when it comes to the sound quality.
Today, we're shining a spotlight on substance use disorder, also known in short as SUD, and we will be concentrating on the stigma surrounding it here in Arkansas. Substance use disorder in itself is a complex and challenging condition, yet stigma often adds another layer of difficulty to those affected. In Arkansas, like many places, misconceptions and judgment can prevent individuals from seeking the help that they need. We need to confront this stigma head on. Instead of viewing SUD as a moral failing, let's recognize it for what it is. It's a medical condition, and it requires compassion and support. It can affect anyone, regardless of background and circumstances. Rich, poor, middle class, educated, young, old, it doesn't matter. And unfortunately, stigma can manifest in various ways, one of which is in the healthcare setting. This stigma affects individuals not only struggling, but also their families and communities. In Arkansas, addressing stigma is going to require a concerted effort from all sectors of society. Education will play a vital role in dispelling the myths and fostering empathy. By understanding the science behind addiction and its impacts, we can challenge these harmful stereotypes. Furthermore, healthcare providers must strive to provide compassionate, evidence-based care to individuals with SUD. By offering non-judgmental support and access to treatment, they can help break down barriers to recovery. As we work to combat stigma, we all need to remember that language matters. Using person-first, recovery-oriented language can help reduce stigma and empower individuals on their journey to wellness. It's important that we continue the conversation and work towards a future free from stigma and judgment. ABHIN did a training this past week in Eureka Springs to implement peer support specialists into healthcare settings. We had 10 participating primary care and emergency departments sign up for this pilot program. Our purpose is to train and implement these peers to work alongside our healthcare providers, to be change agents, and to show the facilities how beneficial peer support is, and what better place than to take this to the front line of defense. Having people with lived experience who have found their way into recovery be that voice for those still suffering, there's nothing more powerful. People get to see for themselves that recovery is possible. If we meet people where they are in their darkest hour, we can save lives, change misperceptions, and make a huge impact on the natural state. My name is Megan Copeland. I am originally from Northeast Arkansas, a small town called Pocahontas. I used drugs and alcohol all the way up to the age of 29 years old. So that's quite a bit of my lifetime that I spent in the problem, right? When I got clean, had to move out of town because the stigma was so heavy in the small town that I was from. I just felt like I needed an escape, like a new start. So I moved to Little Rock, went to treatment, and turned my life around. And so in April of this year, which is 2024, I'll have 11 years clean.
And I'm Caitlin Johnson, and I'm a licensed clinical social worker. I have a background in primary care and behavioral health integration, and working with the unhoused population. Right now, I am a project manager for ABHIN, which is a little bit of a new role for me, going from clinical to more an administrative role, but I still do some clinical work on the weekends at inpatient psych, which has been very eye-opening because you see these patients in primary care and you identify them through screeners, and we'll talk about that, and you do your best with them in the office, and then you send them to an inpatient unit to get care. And now I'm on the other side of that, and I'm able to see how both of these systems work together, and then other aspects of it where they work against each other. So I don't have a personal background in substance use, but boy, has it been all over my family and in my family's past. You know, my father struggled with substance use for 20 years, and my mother shielded me from that for a long time. So I found social work by accident, but it ended up being, with my family's history, and it ended up being exactly where I needed to be. So that I ended up doing social work because I like public speaking, which is funny because now it's sometimes it's an issue, but and I think that substance use, the topic of that and stigma affects every family in the United States. I mean, this is not something that is unique to just anyone, but it's so stigmatized and taboo to talk about that it seems like it is.
Absolutely.
So having this conversation today about stigma and the stigma associated with peers is so important to help break down those walls and encourage people to share their stories and talk about their struggles, because I think they'll find a lot of
camaraderie or community when they start doing that.
So when peer support first came to Arkansas, it wasn't really prevalent in the substance abuse field. I believe that there was some youth peer support, family services, that type of things, even in the mental health field. But for substance abuse, it was just non-existent. So when the training was brought to Arkansas, it was developed from the Appalachian Consulting Group. And there was just a handful of peers in the beginning. And it spread like wildfire. Mm-hmm. So there has been huge improvements, and there's even a career ladder now in peer support. So there's a core level, advanced, and supervisor level. And we'll hear Shawn McCown, which is our guest today, speak a little bit more about that shortly. But even peer support experiences stigma in the workplace. Mm-hmm. So that's a little bit about what we're going to be talking about today as well.
And I think it's important to note that it's not just stigma from the community, but it's stigma from professionals and clinicians that they're working on teams with, which is why we have Dori on as well to talk about her position as a clinician and as administrative leadership for a treatment facility, and asking both of them to share how important it is to involve a peer into somebody's care team, and decrease stigma from the inside and out, if that makes sense.
It's never meant to be an us versus them thing as far as peer support and other healthcare professionals. Mm-hmm. It's meant to complement each other and to give more access to treatment to the people that we're serving.
Mm-hmm. And I know this is something that a lot of people in the substance use treatment arena hear, but multiple pathways to care. But that goes across the board. Not one clinician has all the answers for one patient. And I think it is important for us as ethical providers to say, I know that I don't have all the answers, and there's absolutely a possibility that somebody else in a different field or a different specialty can also help my patient. And I think that's how we achieve better metrics and better recovery and better remission for some of these diagnoses if we include everyone on the care team, because it's really more about holistic care and not siloed like we've been dealing with for the last 50 years.
Absolutely. It's about creating a better life for the individuals we're serving. And, I'm really glad that you said that, Caitlin, because, not all peer support has the answers for everybody they serve as well, but it's the immediate connection of the lived experience that's so powerful. Mm-hmm. So my grandfather recently went to the doctor to get a prescription for an opioid, and he was also prescribed Narcan, which I thought was excellent. Mm-hmm. And, Narcan is now available over the counter in Arkansas.
Mm-hmm. I think it was a very proactive stance for our state government to take to ensure that everyone has access to Narcan, either through their insurance when they're picking up that medication. I know the state right now has a initiative to increase Narcan availability in the community as well. So I think that also is doing its job with decreasing stigma, because I remember conversations with my own family of, well, why do I need the Narcan with this? I'm not using very stigmatized language. I'm not an addict. I'm not misusing this, and how dare they assume that I am? It's now turned to, I have Narcan in my car. I have Narcan in my bathroom. I have Narcan in my mother's a nurse. She carries it in her little work bag too. So I think that is also helping change the conversation about stigma, is just making it a more accessible, normalized part of healthcare, right?
Yes, because overdose isn't always intentional.
Correct. Yeah, exactly. Exactly. Going back to what we said, this could be our grandma or your grandpa who accidentally took 1 to 2 medications.
Forgets that he took his morning dose.
And these medications depress your respiratory system. So it's so easy for this to happen. And I think addressing the stigma that's around is going to save lives.
You made a good point again. The state has done a really good job of saturating the population with naloxone. There's many trainings that go on throughout the state, and naloxone's handed out at those trainings. So don't just throw it away or forget that you have it. You never know who you're going to run across.
We're talking about educational opportunities, and ABHIN has done, I may be a little biased, but ABHIN's done a wonderful job on making sure that there is educational readily and easily available to anyone in the state, really anywhere. It's on our website. So if you go to www.abhinnetwork.org, it's going to have a webinar tab, and that's going to list every one of our webinars that we've done over the past 4 years. And there are several webinars on there where we have hosted people talking about stigma, talking about language and the best things to use, evidence-based intervention. So there's a little bit of everything for everyone, but if you're looking specifically for education on how to start the conversation, how to destigmatize your language, there are several webinars on there that I would encourage you to go look at and learn how to use person-first language and how to make that change in your everyday life and how to encourage other people to make that change.
Today we have a guest here, Shawn McCown, who's the Peer Recovery Supervisor and State Peer Certification Manager for the state of Arkansas. Shawn, thank you for coming to visit.
Well, thank you guys so much for having me. I appreciate that. Yes, I am the Peer Recovery Certification Manager for the state of Arkansas. I am also a peer supervisor in the state. I like spending a lot of time with my grandkids and golfing. That's pretty much what I do on my spare time whenever I have spare time. But I work downtown on Main Street at the DHS building for the Department of Provider Services and Quality Assurance.
Busy area. You like working downtown, Laura?
I do. Especially during the spring and summer, because I get out and I have a walk track that I do to give myself an opportunity to kind of walk. Or before I never did that, so I get to enjoy the downtown just about every day.
Love it. Thank you for jumping right in with the hobbies. That was very helpful. So, give us a brief overview of the role of a peer in the training qualification process.
Okay, the role of a peer recovery support specialist is in the name. We are there to support someone through their recovery process, whatever that looks like for them. We believe in multiple pathways of recovery, and we want to make sure we don't get in a help mode, which will make us want to do things for them. So we always try to stay supportive and support them through the recovery process. Now, how to become a peer? You have to be at least 18 years of age. You have to have a GED or a high school diploma. You also have to do a background check. No violent crimes such as murder or any sexual crimes or anything like that. And you can't have any active warrants. Other than that, there's an application process on arpeers.org that you would go to and fill out an application to qualify to become a peer specialist.
What about clean time? You got to have a clean time?
Yes. You have to have 2 years of abstinence, which means no alcohol and no illicit drugs of any kind for a minimum of 2 years. Now, you can be on MAT, but you have to have proof that you've been on MAT for a period of at least 2 years.
It sounds like the state does a good job of vetting the individuals that go through.
Yes. It's difficult sometimes because you have people who really want to be a part of the program, but unfortunately they don't meet the qualifications. So that's difficult sometimes. But yeah, the vetting process is there for a reason, of course, so they do a good job.
That's reassuring to the employers for sure, and for the people that they work with.
Yes.
So what about the training? Go on to tell me about, is there a career path for peers? Or?
Yes, we have a 3-tier program in the state of Arkansas, which is one of the only in the country. What it is a core level, advanced level, and a supervisor level peer. Each level has its own set of trainings. Each level has their own requirements for certification. I'll give you an example. For core training, you'll go through a week-long core training. And then after you get out of your core training, you'll be assigned a supervisor, and you'll be required to finish 500 work experience or volunteer hours. You'll be required to finish 25 supervised hours. You will be required to get an additional 16 continuing education hours. Once you do all of that, you can qualify to take our state certification exam. And if you pass the certification exam, you are certified as a peer recovery support specialist in the state of Arkansas. And that process continues on the advanced level and on the supervisor level.
Gotcha. So as you move up, is there more required of you, especially in the supervisor level?
A lot more, yes. Especially in our advanced level, we ask our advanced peers to do a lot of public speakings, a lot of trainings. And on a supervisor level, you actually supervise other peers in the process of their certification or helping them with their job description, where at their place of employment. You'll go over that and make sure that the services that they are providing are actually peer services.
Awesome. So what type of environments do peers actually work in?
All kinds, especially in Arkansas. They will do jails, prisons. They'll work on overdose response teams, which go out. They're a part of like a drug task force, so to speak. It's the peer and an officer will go out to an overdose call, and the peer, hopefully, the individual survives, and the peer will provide services for that individual if they want services, if they want treatment, or if they want, just information. They'll provide that information. If the individual does not survive, then they're there for the family, to provide those same services for the family. There's peers in MAT clinics. There's peers in treatment services, whether that's detox, inpatient, IOP services. There's peers there. There's peers in what we call PAC programs that provide services for prisoners. What else is there? Peers.
Sounds like that's a real boots on the ground type of position.
Yes, and also mental health facilities. I didn't mean to leave those out. We have peers that are mental health specific, and we have peers that are substance use specific. Then we have co-occurring. So no matter your area of recovery, you can be provided peer services.
So Shawn, we're here to talk about stigma today. And we know that there was a study done in 2019 that showed over 70% of peer professionals end up experiencing some kind of either a weekly or even daily microaggression in the workplace. So as a peer supervisor, as a peer yourself, have you experienced that stigma? And what can that look like?
I've definitely experienced stigma in the workforce, especially. A lot of it has, for me personally, a lot of it had to do with perception, the confidence in my ability, and it had a lot to do with, them thinking I was trying too hard. And what I mean by that is they would automatically view me differently as soon as they found out I was in recovery myself. It's as a professional all my life, as I was looked at, I can see the difference. Now, as a professional in recovery, it's like, I don't know, it's just something changes. Their outlook towards me, the way they talk to me, just automatically it just changes. It's also like they're waiting for me to fail. I don't know how to explain it, but it's just that feeling you get from someone, maybe their body language or maybe some of the things they say. It's just, it's like they're thinking it's just a matter of time.
It's like you're faced with doubt right off the bat.
Definitely. Yeah. And then it's like, if I am doing well, it's like, well, he's just trying too hard because, he's trying to prove himself. Well, sure, I'm trying to prove myself. That's what I tell him. I definitely, but the reason I'm trying to prove myself is not what you think. Because I want to be able to do a good job for the peer that I'm servicing, not for you.
Right.
But for the peer. So definitely stigma is not every day, but it's every week at least. Especially like in staff meetings and stuff like that. It's like when it's my turn to speak, I may get 30 seconds when everybody else gets 5 minutes. Seriously.
Okay. So how long have you been a peer?
I have been a peer since 2019. So going on 5 years now. I was working for a nonprofit mental health organization at the time when the peer movement kind of started here in Arkansas. So I didn't join right away. I wanted to kind of see how it went. Was this a fly-by-night situation? So I gave it about a year and a half before I decided to join the peer program. And after that, it's just, it's for me, I'm an all or nothing kind of person. Once I commit, I commit, that addictive mentality that I have, So, but yeah, it's almost 5 years now.
So I can imagine the stigma that you're facing professionally and then just out into the community can be really hard for you to deal with just kind of on a personal level. How do you talk yourself out of the things that they're saying to you, or how do you keep yourself going after experiencing stigma like that?
Well, thankfully, I didn't get into the peer program till I was about 5 years into recovery. So I had a really good, solid foundation for myself, thankfully. That's why we have that time frame before you become a peer, is to kind of give yourself some time for a solid foundation. And I have always had a mentality, even as a little kid, that I wasn't going to let anyone change me. And it's worked out well, but it's also worked out negatively. So when I hear those type of things, I used to always think, well, I'll show you. Now I really don't say anything. I don't react to it. I want my work to be the proof, not my words. And that's what I tell my peers that I supervise when they run across the same thing. It's like you've got to get to a place where that doesn't affect you in your job performance, because your job performance is what's going to speak for you. And it's really worked out really well for me. Some people say you either love Shawn or you hate Shawn, and there's no in between. And I really think it's because of the mentality that I bring. It's like, this is who I am. You're either going to like me or you're not. I'm going to be honest with you. I'm going to be upfront with you. And what happens after that is your choice, not mine.
Yeah, you actually kind of answered the next question I was thinking of, is what do you tell new peers when they do experience some of the stigma? It sounds like community is such a big part of the peer profession. Do you guys lean on each other a lot when things like this happen?
Without a doubt. That's the one thing I can say about the peer community. If I could say a lot of things, but that's one good thing to point out is we completely rely on each other. We have a great network. All of our supervisors, we have 19 supervisors in the state. We are always calling each other, emailing each other, asking each other questions, about, hey, this situation happened. How would you have handled it? So we're always communicating with each other. We always have an open line of communication with our peers, like the peers that I supervise. They always know they can call me. They can always know they can text me, email me, and I'll do everything I can to get back in a timely manner and help them through whatever they're going through. But it works the same for all of our supervisors. They're always available for their peers, which really helps, especially when we're trying to establish the peer profession here in Arkansas. It's been around for decades, just not here. So trying to establish this profession here we've really bought into, we've got to help each other do that. And we meet all the time. We have meetings all the time, mostly good, but we have tough conversations with each other, and we respect each other afterwards, because we all understand that we're here for the profession and not for ourselves.
It's good to see the peer community grow in Arkansas. As a smaller state, we are sometimes further along in time frame to receive trends that are going on. But like you said, peer support's been around for years, and seeing Arkansas actually pick up on that is great movement forward.
Yeah, we've had mental health peers scattered in the state through the years, but not a movement, so to speak.
Mm-hmm.
2017, we started a movement of peer recovery support in Arkansas, not just scattered here or there. We have hundreds and hundreds of, peer specialists now.
Shawn, how do you think clinicians talk about people with SUD when they first start working with them versus people who do not have that colorful background?
You talk about how clinicians talk about people with SUD. To me, in my own personal experience, they continue to use whatever language they were using before that met me, because that's what they're used to.
Give me an example of the type of language you're talking.
I can give you an example of a place that I worked that we had a couple of peers, but it was mainly all clinicians. And we would have meetings, and say a peer would leave AMA. And I just give you that as an example. Some of the clinicians would use very stigmatizing language like, oh, they'll be back. This is the 7th time they've been here. I wonder how long it's going to take them before they come back this time.
I've heard them called frequent flyers.
Oh, definitely. And once they start working with a peer specialist and they see that, hopefully that language starts to change. What I witnessed is that it did change. Right? Maybe that's not for everyone, but I got to watch it happen, which was a great experience for me to see, was that the clinicians that I worked with, after they saw really the value of a peer specialist and what we could offer for the peer as far as services go, they really started changing how they were saying things, how they were acting towards the peer and us. So it was a positive experience for me. At first it wasn't, because I had to get through that stigma.
Sure.
But once, again, I'll go back to the proof was in our work. That experience that they got to witness firsthand of how that peer changed, even in a small time frame, really started changing the way they looked at us and even the peer themselves.
If you could speak to a care team member that may be struggling with stigma against people with SUD while working with a peer support provider, what would you say?
Well, the first thing I always tell them is that I want to understand their experience. It's when they're struggling with stigma, there's a reason why. And I want to be supportive of that reason, whether they're a clinician, a doctor, a nurse, that's of no significance to me. There's a reason why you feel the way you feel. And I want them to know that I understand, that I don't hold a grudge against them for feeling that way, because there's certain beliefs that I have, and I would really want someone to ask why I feel that way, So that's the first thing I do is I make sure they understand that I understand where they're coming from. The second thing that I always try to do is I use my lived experience with SUD as kind of like a teaching tool for a staff member. It's like, if you've never experienced it, you don't know what they've been through. Let me tell you what I've been through, and sometimes it does change their perspective of someone who has an SUD, substance use disorder, because the stigma out there is it was their choice, they made that decision. Well, that's true at first, but it doesn't always stay that way. There's a time in someone's life of having a substance use disorder that the choice goes away. Mm-hmm. A lot of clinicians may have be challenged with that. They don't understand that part of it. So I always try to share that part of my lived experience with them. And then I always go back again. I'll go back to allow my work to speak for itself. Okay, give that peer a chance, and that peer specialist a chance to work together and to see the fruits of that work. Right, and then we can go back and let's have another conversation about that. I am all about communication. I always tell everyone I was a world-class liar. As a person, I call it a practicing addict. So I always I communicated the way I wanted communication to go. Mm-hmm. Now I look at it completely different. As I want to talk things through. I want to know your side of it. I want to know your perspective, so that we can come to hopefully a good conclusion. So that's why I tell the staff, it's like, give us that opportunity to work with that peer. Now that you have a little understanding of lived experience and what it's like, give us a chance to work with them, see what happens, and then we can kind of go from there. And like I said earlier, it really changed the perspective of the clinicians and the staff that I worked with at that facility I was working with. Completely changed it. So.
Thanks to your hard work, because some people don't know if they have the capacity to work on that stigma, and it sounded like you took it on head on and put a whole lot of effort behind it. So
yeah, and it wasn't just me. I mean, me being the peer supervisor, I was kind of the front man, but it was all the peers. We had several peers that worked there, and that was always the message I gave them. Was the same message I keep saying over and over. Is let your work be the proof.
Mhm.
You know, let me handle all that word. I'm gonna keep that away from you so you don't experience that. Okay, I'll be the brunt of that. You know, being the peer supervisor, and that's what I was for them. I was kind of that shield. You know, there were some things that happened immediate, and there was nothing I could do about it. But I always try to be their shield, and just always told them, let your word be the proof.
So the point of having this conversation about stigma is we're hoping that it encourages change, right? So it's a community effort that we need to make in order to change some of that stigmatized language or stigmatized thought process with peers. In your opinion, how can we start today? How can listeners start changing and decreasing stigma in just everyday actions?
Active listening is probably one of the keys that everyone can start doing. There's a huge difference between the behavioral health professionals that have educated them on what peer support is, than behavioral health professionals that have not. And what I see there is that someone took the time to listen to what peer support really is, and not form their own opinions or got an opinion from someone else. All right. Over and over, we tell people that we are a part of the team and we are not there to replace anyone. We're there to support and do whatever we can to make the lives of the individuals that we come in contact with better. And honestly, behavioral health, some, I won't say all, but some are challenged by that. Right? And I understand that. I get that. You know, there's behavioral health professionals that have been around for many, 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 many years and are used to doing things a certain way. And when something new comes, you know, it's hard to grasp that. I understand that, but I just ask everyone to listen. If you're at a conference and there's anything about peer support, go listen to it. You know, if you see anything like this podcast, listen to it. You know, anything on the news, listen to it. And educate yourself before you decide to form an opinion. Because if you really knew the value of a peer specialist, I think your perception would definitely change. Because I've heard it all. You know, why are you guys getting paid what you're getting paid when all you do is this?
Mm-hmm.
You know, why are you guys why are you guys able to do this when, you know, you're not even a real profession? Yeah, I mean, I've heard everything, you know, but once someone sits down, it's like, oh, you guys have to do all of this? Oh, you guys get trained on this? Oh, things start to change a little bit, but they took the time to listen. You know, and I think that's really the key to the community, is just take the time to listen. You know, I know anything new is tough, but, you know, I think that's the difference that it would make, is there'd be so much buy-in in the community of what we could provide someone with a substance use disorder or a mental health disorder, that they would jump at the chance to hire a peer.
Mm-hmm.
So that's my hope. You know, as we get there someday. You know, it's going to be a challenge, and we're okay with that. You know, so
Active listening, and education.
Yep.
Lean into that education.
Definitely, without a doubt.
Shawn, thank you for sitting with us and giving us all this information. I've worked with peers for the last 3 years, and you taught me some stuff today. So I really appreciate it, and I hope that is something that listeners can also benefit from today.
Thanks for
Appreciate
taking the time to visit with us, Shawn.
Thank you, ladies. I appreciate you guys having me.
So we're here with Dori Haddock. She is a licensed clinical social worker and the regional director for the Arkansas and West Tennessee area Bradford Health. Dori, thanks for joining us.
Thanks for having me.
So we know you're doing a whole lot of fun stuff professionally, but tell us about Dori.
Well, I'm the mom of 2 girls, 19 and 16. I've been married for 23 years. And we like to go out to eat, go shopping with my youngest, camping. We camp a lot. So we have a camper. We love to do that. And that's pretty much, you know, pretty simple. We just like to be outdoors and be together as a family and hang out and laugh. We laugh a lot. So that's good.
Good. Especially in the field that you work in, you got to do a lot of self-care.
Yes.
Absolutely.
So participating in that family time, getting outdoors, we know that's healthy for you. So today we're going to talk about peers and stigma, and we're interested on how you have integrated peers into your clinical practice, into the treatment facility that you work at. Can you tell us a little bit about peers?
Sure. So Bradford Health has been in business for over 40 years treating addiction, and they've kind of always implemented that peer model, but it wasn't called a peer support program. So it was basically we had people in recovery working in our treatment center and answering our phones and motivating for people for treatment. And as the peer movement started in Arkansas, it really caught hold to me because it just made perfect sense that if you utilized our peers in their very beginning of stages of treatment, then, they have a better connection with the caller that's calling, and they can help motivate for treatment. And so we always kind of had that model at Bradford, but when we partnered with a local hospital and started a residential and detox program inside that hospital, we actually were the first company to employ peer support on the company's dollar and not on grant funding or in that capacity. And so it was pretty, I think, revolutionary. It was exciting to start that, but it definitely was some learning curves of what that looks like in employment. And, when you work for a substance abuse company, you don't think twice about hiring somebody in recovery or somebody that has a past or felony charges. And then when you work with other companies that's not necessarily their forte, there was definitely some learning curves of how to incorporate them into a medical model.
Mm-hmm. So it sounds like Bradford really fully committed to the idea of peer support specialists being involved in the care team and knowing that benefit, just as it's important for a nurse to be on that care team, for a social worker to be on that care team. It sounds like they were integrated fully.
Absolutely. They are an essential part of our multidisciplinary team. I have as many peer support specialists as I did counselors.
So can you tell us what it looks like to have a peer on the team? How does that workflow go for you guys, and what are the benefits of that?
Sure. So we have a peer support on site, not always have to, typically, if not more, from 8 a.m. until 8:30 p.m., 7 days a week.
Wow.
They're divvied up into different roles when they're on the floor. So either we have the biggest part is they navigate our intake area and our call admission center. So like anytime that somebody calls in for treatment, our peer is the one that answers the phone, gathers information for the clinical team to look at and determine level of care and what appropriate, and then after that, they motivate that patient to come into treatment that day. We know that if there's a lapse in the call versus coming to treatment, that the chance of that person following up with care is less likely. So that's one component. We implement them, like I said, they sit in our morning meeting, which is with every discipline, a member of each discipline. They do groups every single day. They take our patients to the gym for part of the time. They are out on the floor whenever there's breaks. They're integrated with them, just kind of walking around with our patients just to be available for talking during the day. They help with discharge planning from the very beginning of how do we get you into long-term care. I think we had like a 65% of our patients went to long-term care in 2023, if not more than that. They're really, really instrumental in our leaving AMA, which is against medical advice. And so we typically find that our patients start getting really either uncomfortable or really comfortable around day 10 to 13 and want to leave. And it's kind of like, I'm out of here. And the first thing that we do is we incorporate a peer support to come and talk with that patient. Our AMA rates, the average is about 20% is what people try to keep it below. And from 2022, it was like 20%. And this last year in 2023, it was 9%.
Wow.
And so I think our peers are such a huge part of that you can't argue with numbers. I switched careers because I didn't want to do any type of accounting or math. And now all I do is accounting and math and percentages. But I'm starting to learn to like it because it really does add up. And you see the benefit, and that can take something back to the hospital that's quantifiable, that I could say these are really why we need this role. I will say working in a non-substance abuse facility, such as a hospital, peers are not anywhere else inside the hospital.
Right.
And so one of the things that you've learned working in hospitals is they like to share staff. So like if you have a nurse that we're not right census or we're too low, we can transport them or move them and float them to another floor.
Mm-hmm.
There's not that opportunity with peer support. And so when budget cuts come or peer positions, things need to be cut, it's usually the peer is the first one that's been identified. And so there's been a lot of trying to say, but look what they're helping us do.
Right.
And so I will say the hospital's been very inviting. They've been very welcoming, but it definitely has been just an educational opportunity for us to just explain a little bit more about why they are so important.
Yeah. So it sounds like peers are multifaceted in their ability to make so much change with the patients that you guys see. And the numbers part of it is, I joke that too, because I'm a social worker as well. And I make jokes about how I'm not good at math or anything like that. But we end up having to use a lot of data to advocate, right? For our patients and our population. So we're going to spend some time talking about stigma today. And we know that there was a study done in 2019 that showed over 70% of peer professionals end up experiencing some kind of like microaggression, whether it's weekly or daily at some capacity. From your position, have you seen that stigma happen? Have you heard that stigma happen? Could you share your experience with that?
Sure. I have. And I think that it's not as overt as we think it is. I think for ours, it's when people make little comments forgetting about who's in the room. So addicts saying things like, well, that quote unquote meth head or crack head or whatever it may be. And they're not meaning to intend to be mean, but it's like, okay, well, you're actually sitting here having a conversation with one of your coworkers that has been down that route and is in recovery. Yeah. And so the language that's used around, we try to look at that. I will say that we are required to do, and I witnessed this, the biggest example I can remember is there's a certain type of training that has to happen for any time you work in a hospital, where you learn how to protect yourself, safe training. Like in other facilities, it's that crisis prevention intervention, CPI. For the hospitals, it's called SAFE. And the instructor, who's no longer there, but at the time kept saying, well, when these drunks show up and these, you get these people around here and this is how you'll handle that. And we had 4 or 5 of our peer supports were in that training. And so they brought that back to us, and it was an opportunity for us to go to that leader and say, you need to be careful how you're presenting this in a hospital setting, because it's not just our peer support specialists that work in that hospital, they're in recovery. And I think that's what, when we first started talking about going into a hospital, it was kind of like, well, we don't want, quote unquote, those people here. Well, they're already here. Right. They're wearing stethoscopes and lab coats and nurses. And so, one of the things that Bradford was known for years has been treating healthcare professionals. So we were the largest treater of healthcare professionals in the nation for like 5 or 6 years. And so we treated impaired physicians, nurses, anybody that held a license. And so that's kind of the biggest stigma I've seen. And I think also just assuming that because they're working a peer role that maybe they're not educated. Right. Or don't have an educated past. Like we have a peer that worked for me that has chosen to do this as their second career, and the first career is running their own business, So I think it's easy to make those judgments of people when you don't really know who anybody is.
Right. What is the biggest way you found as a breakthrough to the leadership when they are expressing stigma towards a peer like that?
Education. Like really just explaining to them like what the disease of addiction is, and that if, nobody chooses this path. And so I was trying to help them that, yes, maybe they did have a sort of past, but have you ever done anything in your life that you wouldn't want anybody at work to know about, Right. And that's always kind of the big joke I tell everybody is like, my daughter keeps saying she wants to run for president. And I'm like, I've got too much stuff for you to be running for president. Like, I don't. And I think that's kind of everybody it's real easy to take inventory on somebody else. And so it's educating and reading and talking to them and being open about them. I've encouraged a lot of people that don't know what we're doing on our unit to come sit in, spend a day. That's kind of what we've done with a lot of our staff that we've been bringing on that are not peer supports or therapists or nurses is come spend a day in treatment and know what it's like to be that patient and go to groups with them and see what it's like to have to get up in the morning and make your bed. And so it's usually after a day of that the attitude completely changes. I will say an example is we had an ER nurse that really gave us trouble a lot of times, and they had to come do a rotation on our floor for a schedule, and the attitude was night and day different. Wow. Even told me so. It's like I made so many judgments about this program, about the people that not only the peer support, but our patients. And he was like, man, these guys are really like getting it and they're trying hard and your program is structured. And it was like once they set foot on our floor and saw what we were actually doing, the whole attitude changed.
I love that. I appreciate you letting them come on and see that.
Yeah, I mean, employees. I'm not letting just anybody from the streets come in. But, man. It's not just a free-for-all. We do have to follow HIPAA and all that good stuff. But
So now that you have peers as part of your care team, can you talk about the general benefits and your perspective on peers and how it's changed?
So as a clinician, I think it's really important for us to know our roles. And so I think what peers have done is they can do something different with our patients than you can as a therapist. And although that causes some controversy sometimes about, for example, if our patients, once they leave our facility as a clinician, I don't get to have contact with that patient.
Mm-hmm.
That is considered a dual relationship. It's under our unethical guidelines. And it's the polar opposite for the peers. So they can reach out, I think, and have that connection and that connectedness after discharge that we're not able to do as clinicians. And I also think being able to be like, I've been there, I understand that. And there, even for my therapists that are in recovery, that's still a real fine line about how much you self-disclose and how much you don't. And so I think it just gives an extra level of support. Like it's just another layer for that patient.
I think there's some aspects too, working with a peer, there are just some things you don't have to tell them that you have to tell a clinician as far as perspective. Sharing certain parts of recovery, you may have to explain in detail to a clinician so they will understand. Hopefully they are empathetic, but there's some things you want to get across. But with the peer, they're going to be intimately aware of the things that you're going through and headspace that you're in. So I think sometimes that's helpful too. Wanted to circle back on the conversation with leadership. There may be people listening today that are wanting to take the idea of implementing a peer into their primary care clinic or into their hospital, but maybe they're afraid to approach their leadership with it. What advice would you give to that person as far as approaching that topic?
Just be honest. I mean, it's sometimes the hardest conversations are those that you don't want to have. But once you do, people are way more perceptive and receptive of things than you understand. I think the big question when talking to leadership is having what you want to do with that peer, what their role is, and having like some evidence of why you feel that's going to add value. Mm-hmm. One thing that I've learned in being more on the business side of things now is what leaders want to know is how does this add value, mm-hmm. and financially, how is this going to benefit us? And I know I'm in this, and I've said from day one, my philosophy in being in leadership myself has always been put patient care first and the rest comes. And although those aren't the numbers that people want to hear. So you have to keep in mind that we are running a business. And when you're running a business, you have to have those conversations that you can quantify the value of that peer. I will say from somebody that is in leadership, my peers are probably some of my best employees. They arrive on time. They're grateful to be there. They do what they're asked to do. We just don't have a lot of the same entitlement, I think, that sometimes you get from other professional areas. And so I think, just to directly answer it is to have those hard conversations, but also have some evidence and some financial data to support, because that at the end of the day is honestly what everybody's looking at is what is this going to cost us, and will it give us any revenue coming in on the back end?
Right.
Well, Dori, in your opinion, how do we combat this stigma just in everyday life?
I think been involved in this peer movement here in Arkansas from the beginning, and there's been a lot of conversations that I've had that were not always really comfortable with. I think people being like, "Well, you're not in recovery, you don't get it." I may not be in recovery, but I certainly am actually involved in it every single day, and so I may not be in it, but I also have been living in this field for over 10 years now. And where we were 10 years ago as a state and where we are now as a state is night and day different. I think it's been a 180, and I think it's because you've got people in positions that are willing to have these conversations. Mm-hmm. You've got people in the state level that's willing to go to bat for our peers, having legislation changed, having conversations changed, languages changing. And so, I even see it sometimes even on a social media page. It's pretty much mainly all peer support's on. They'll call each other out on it. Don't forget, we don't use those words anymore. We use these words. And so I think just having those conversations and as in anything else, not taking it yourself too seriously, mm-hmm. being able to have a conversation, laugh, and be like, yeah, I know that you can call yourself A, B, C, and D, but it's not okay for me to call you that. And just having that understanding.
Again, we want to thank our guests, Dori and Shawn, for the work they do and their willingness to share their stories and perspectives, as well as thank you, our listeners, for your time today. We hope we see you back for future episodes of the While You Wait podcast. If seeking CE credit, please be sure to follow the instructions on the ABHIN website and follow or share this episode with colleagues, friends, and family. Until next time, take care.